Good morning, everyone. Thanks for being here. And thank you for joining me on the past, present, and future homelands of the Squamish, Musqueam, and Tsleil-Waututh peoples. My name is Sarah Chown, and I am the Executive Director of AIDS Vancouver. In this place we today call Vancouver, HIV activism started over 40 years ago in a time of unrelenting bigotry, discrimination, and prejudice when an unknown virus without testing or treatment was killing people at an alarming rate. While I am too young to have been there myself, I'm so grateful to hold stories of some folks who were and to have the pleasure and opportunity to work and learn alongside these experts. As someone in the HIV movement today, I have a sense of responsibility to these experiences and that they must inform and guide us in our work today. At times in small steps and at times in big leaps, some things have changed since those early days. Those changes have been hard fought, some won by those who are no longer here. From the beginning, it has been people living with HIV and their loved ones who have shown up to take care of each other. That's meant sharing breaking HIV research information in a time before the internet and effective medication, visiting each other during hospital stays, and changing policies that harmed people living with HIV. I am motivated by HIV activists, past and present, who have accomplished so much and made our work possible today. Even as I have gotten to hear firsthand from people, learn their stories, and hear about the loss and the fight, it's impossible for me to really understand the intensity of the pain, loss, and discrimination faced by those first impacted by HIV. We call this group long-term survivors, people who have been living with HIV for most of, if not all of, my life. This group includes people who were born with HIV, who I got to meet during my time at YouthCo, as well as people who were diagnosed with HIV as young adults in the 80s and 90s. You'll be hearing from one of these people, Glenn, shortly. It's because of their fight and their voices that HIV today is no longer a death sentence. Their fight and voices have helped to remove barriers to HIV treatment, and it's because of their fight and their voices that we are here today. We're here with an update on the work we've been doing and where we still need to go today. Specifically, we're here to talk about a campaign we launched in March earlier this year. It is a campaign to provide meaningful access to long-acting injectable HIV treatment for British Columbians who need it. Since the launch of the campaign, hundreds of concerned individuals have raised their hands in support of broad access to long-acting injectables, and it makes sense as to why. This treatment makes life better. Long-acting injectable HIV treatment, though a mouthful, basically means folks living with HIV are able to switch from swallowing one or more pills day in and day out to a single doctor's visit for an injection every 8 weeks. Long-acting treatment eliminates the daily reminders of HIV, concerns about privacy and confidentiality, and lets people live their lives. We've been passionate advocates for this life-changing medication, and personally, I am motivated by the people who have been waiting for years, and in many cases, decades, for options other than daily pills. We continue to meet with those living with HIV, in addition to officials from the Ministry of Health, as we advocate for this access to this medication. Unfortunately, we have not yet been given the opportunity to engage directly with the BC Centre for Excellence in HIV/AIDS. Decisions about what treatments are available must be informed by the community of people living with HIV. These are decisions which must be based on evidence and lived experience. People living with HIV deserve to be heard, and it is especially important when they are speaking about something which has made a measurable difference in their lives, like treatment. People living with HIV have always pushed for meaningful access to HIV treatment and information about the options that might work best. That's included pushing to ensure research includes women and gender diverse people, removing financial barriers to getting the medications once approved, and ensuring people living with HIV get to be part of the decisions, both about their own individual care and what medications work best, and the policies that determine what options are available and what care looks like. I want to be blunt here. Long-acting injectables were approved in Canada more than 3 years ago, and people living with HIV in other parts of the country have access to long-acting injectable medication right now. They are getting access to life-saving and life-changing care, but British Columbians are being left out. And that is especially troubling because of the leadership our province has shown on other issues related to HIV. Today in Ontario or Quebec, people living with HIV can choose long-acting treatment, and with that decision, get to let go of the fear that someone will find their daily HIV pills and out their HIV status. In these situations, people may be excluded from their social networks, kicked out of their homes, or be subjected to physical violence. So the obvious question is, why not here? Why is it that people living with HIV in BC can't truly access this option that can change their life? Long-acting injectables aren't available to every person living with HIV. Instead, people living with HIV who want this treatment and their healthcare providers have to get through uniquely restrictive criteria and a uniquely restrictive process. This criteria says people are only eligible if they cannot take oral HIV medication, such as folks who have a swallowing disorder or a malabsorption issue, both of which are very exceptional circumstances. At the same time, the criteria here in BC also says that a person's HIV medication must be working for them in order to be eligible. Think about that for a second. How can someone who is not able to swallow HIV medication have HIV medication that's working for them? It's a contradiction that doesn't make sense, and it's a huge barrier to meaningful access. This is just one of the differences between the criteria here in BC and the criteria elsewhere in Canada, and the criteria established by the Canadian Agency for Drugs and Technology in Health, the interprovincial body that the BC Ministry of Health already relies on to make decisions about other types of medication. CADTH already recommends the adoption of long-acting HIV injectable treatment. Ultimately, we want decision makers in BC to change the criteria and the process to better reflect the recommendations at the national level. We are asking the Centre for Excellence to facilitate access to long-acting treatment for people who are 12 and up and whose HIV treatment is working well, referred to as virologically stable and suppressed in more technical language. Of course, we recognize that in some patients, injectable treatment may need to be discontinued if there's adverse events or there's no longer virological suppression. Our goal is meaningful access to long-acting treatment, both Cabenuva, the option approved for use today, and the long-acting treatment options we know are coming down the pipeline. We believe those living with HIV need another safe and effective option for treatment should have it, for as long as we continue to see innovation in HIV treatment. Our recommendation of what needs to happen in British Columbia mirrors the coverage criteria recommended at the national level, and it's what has been adopted by other jurisdictions in Canada that are already providing access. I am here today to again invite the members of the BC CFE and the Ministry of Health to come together and eliminate current roadblocks to provide access to long-acting injectable HIV treatment. If the rest of Canada can do it, so can we. We have seen BC do it time and time again, and we want to see this track record of excellence applied to long-acting HIV treatment too. In fact, the BC Centre for Excellence will be in this building later today, providing an update on the advancements made in HIV/AIDS care over the last 30 years. Undoubtedly, this organization has been an essential part of the HIV response and made it possible for people to become long-term survivors of HIV. I do not seek to dismiss these successes. I am here to call on them to continue their leadership as the long-acting HIV treatment era begins, holding tremendous potential to improve the lives of people living with HIV. We're here to figure out how we can meaningfully connect British Columbians to this first, very exciting, complete long-acting HIV treatment option. We also know that long-acting treatment will not be for everyone. Some people will continue to use the oral medication options that are available now and into the future. While we want to ensure daily medications remain an option, We also want to see people living with HIV and their care providers have the choice of long-acting options where needed. Many of these people living with HIV have been waiting for years, even decades, knowing a long-acting option is on the horizon. And that's why we started this campaign, driven by the questions our teams get every week from people living with HIV about how long-acting treatment works and when they can access it and what it might mean for them to do so. We've increased awareness and focused on public education, as well as meeting with lawmakers and regulators on this issue. I want to let the decision makers know we will continue this conversation and invitation for as long as needed. We will continue to stand hand in hand with people living with HIV, community organizations, and healthcare providers who know the difference meaningful access to long-acting injectables can make for those who need it most. I would like to acknowledge and thank our local MLAs and the senior officials of BC's Ministry of Health who took time to hear our concerns. I am looking forward to your response, and most importantly, I'm excited to see all of us come together to ensure people living with HIV can access the care they need. People living with HIV have long been advocating for what we're asking for today: equitable access to treatment. Where a person lives, in particular on what side of a colonial border a person lives on, should not be a limiting factor in the care they receive. We are showing up every day in the fight against HIV stigma and in the work to ensure people living with HIV can thrive. This work is continuous, and when it comes to treatment, we need more tools. Time is of the essence, and people living with HIV in British Columbia have waited long enough. With that, I'm very excited to introduce my colleague, Glenn Townsend. And as just a quick housekeeping note, we will be around for questions at the conclusion of the formal program. Thank you so much.
Thank you, Sarah. My name is Glenn Townsend, and I am a long-term survivor. I was diagnosed in 1984 before medications. And without the efforts in our province here by doctors like Dr. Conway and the BCCFE, I would likely not be here today. Many times over the years when I've been in conferences at other parts of the country, the medications I was on were not available in other areas. And I had quite a challenge to get to undetectable. That being said, recently we have seen a decline in the research and studies and lack of approval of new medications onto our formulary here in BC. While there was a long-acting injectable trial here in Vancouver, there's still not meaningful access years later. The community is disappointed that there has been so many barriers to getting the injectables here. For someone like myself, taking multiple medications and lots of pills every day, it won't have as much impact. But for someone newly diagnosed, younger, vulnerable, from populations where there's a lot of stigma around HIV, the injectables could be a game changer. Also for people at risk of violence. These are things that can assist and keep people safe. There's still a lot of stigma of HIV in our community. Also, for those who are unhoused and precariously housed, it can also be a game changer because daily pills are a problem. And we know with the sweeps in the city over the last while of the de-encampments, people lose all of their stuff on a daily basis sometimes. And trying to take medication can be a real problem, even though we do have some amazing community-based programs to distribute medication on a daily basis. We also know that there are other injectables coming down the pipeline, and they will be longer acting, and they will have a huge impact on HIV moving forward. This is a really good place to start to see how we deliver these things and how they work out. And then we can really realize the potential as we move forward. With that, I would like to introduce our next speaker, Dr. Brian Conway, head of the British Columbia Infectious Disease Centre.
So thank you very much to Sarah and to Glenn. My name is Brian Conway. I'm the medical director of the Vancouver Infectious Diseases Centre and the newly founded Vancouver Urban Health Centre. Ce sera pour moi un plaisir de vous adresser la parole dans les deux langues officielles. Unlike Sarah, I was there at the beginning. I've been involved in the field of HIV since I saw my first cases, perhaps people just like Glenn at the Royal Victoria Hospital in Montreal in 1984. I have followed the evolution of treatment options until the current era, when HIV right now can be easily controlled in the long term, often with just taking one pill once a day. This gives people living with HIV infection the hope that although they cannot be cured, their infection can be controlled for the rest of their natural lives. However, for some, as you've already heard, this is not the best option. They worry about someone finding their pills. Over time, they may be forgetting to take their pills as regularly as they did in the past, and every time they take a pill, they're reminded of the fact that they have HIV infection. So some would prefer an alternative, much as women who take contraception take a long-acting contraceptive as opposed to a daily pill. It's a choice. So over the past several years, an injectable combination of antiviral medications, cabotegravir and rilpivirine, known as Cabenuva, has been evaluated in clinical trials and shown to be safe and effective in the setting of a switch from a pill to an injection, in the situation where the pills were highly effective. A recent study has reinforced the benefits of Cabenuva in comparison to a pill known as Biktarvy, which happens to be the most commonly prescribed HIV combination therapy in British Columbia. This study was called SOLAR. It was presented for the first time at international conferences earlier this year. It included 670 participants who were on Biktarvy and responding to it. They were randomized or assigned on a 2-to-1 basis to receive either the injection every 2 months, the Cabenuva every 2 months, or to stay on Biktarvy. So 447 people received Cabenuva, 223 received Biktarvy, and I should note that within the SOLAR study there were 52 Canadians. So after 12 months of either switching to Cabenuva or staying on Biktarvy, there was no statistical difference. The two were undistinguishable statistically. 90% of people were still responding to respond to Cabenuva. 93% of people were responding to Biktarvy. Now, at the beginning of the study, almost half, 47% of participants reported always or often experiencing one or more of the challenges in taking pills every day, such as being worried about people unintentionally discovering their HIV status, being worried about forgetting to take their HIV medications, feeling that taking their HIV medication was an uncomfortable reminder of their HIV status. Half the people were saying that. So after a year, 90% of people who got assigned to Cabenuva, they said, okay, you were in the study, you did a great job. Now you can go back to the pill. They said, nuh-uh, I'm staying on the Cabenuva. I like this. I want to stay on Cabenuva. So the top 5 reasons, they said, for wanting to stay on Cabenuva is I don't have to worry as much about remembering to take HIV medications every day. It's more convenient for me to receive injections every 2 months. I do not have to carry my HIV medication with me. I do not have to think about my HIV status every day. I do not have to worry about others seeing or finding my HIV pills. Confirmed virologic failure. People are worried, well, they're going to be on the shot. It's going to fail. And this is not a good thing. When all the people that were enrolled in the study, it happened in exactly 3 individuals. Now, to be fair, these 3 individuals had viruses that were resistant to the Cabenuva as a consequence of the treatment failing. But it remained sensitive to other agents, and it was very easy for these 3 individuals to go back on a pill that would work for them. It's just an issue of monitoring. So in other words, this risk of resistance occurred in 0.67% of the people that were assigned to receive Cabenuva, and effective alternatives were available to them. Now, in terms of side effects, the main side effect was obviously related to the injection itself, the process of an injection. And 98% of these injection site reactions, as they are called, were considered mild, and they resolved within 3 days or less after the injection having been given. In 2% of cases, 2%, the injection site reactions led to the need to stop the Cabenuva therapy. And what do you do then? You just go back on the pills. Cabenuva is not for you. Now, as has been mentioned, Cabenuva has been approved by Canadian regulatory authorities for over 3 years. The exact date is March 18th, 2020. It is approved as a complete regimen. That's all you take for your HIV, for the treatment of HIV infection in patients who are 12 and over, who weigh 35 kilograms or more, to replace an antiviral regimen that they are taking that is actually working at that particular time. The injection can be given every 2 months, and to date, 1,284, I found this out this morning, 1,284 Canadians are benefiting from Cabenuva therapy across Canada. We're asking that it be made available in British Columbia as it is in other jurisdictions. Now, the objections that have been raised are legitimate, but at this point in time, they've all been addressed. It is as effective as the most commonly used oral treatment for HIV, as a SOLAR study has shown us, when it's prescribed in the proper setting, as a switch strategy in those already responding to therapy. It's safe. Only 2% of people developed a side effect that made it such that they had to stop Cabenuva. The issue of resistance occurs in less than 1% of cases, and it can be addressed by switching back to a pill. And although this shouldn't drive medical decisions, people like it. Almost everyone on Cabenuva for a year wants to stay on Cabenuva, even when they're offered the opportunity to go back to a pill. So I represent a center that has treated people with Cabenuva in clinical trials. It's administration by injection. People have said that this is very complicated. It's a bit more complicated than, say, administering injections for syphilis, for the treatment of syphilis, that we do on most days. The cost in other parts of Canada is equal or less than the cost of pills when you measure it over an entire year. And there are clear strategies that have been put in place to deal with the fact that someone may miss their injection, be late for their injection, or something else happen. There are strategies to deal with this. It's an issue, but it can be addressed. Mesdames et messieurs, les données probantes sont très claires. C'est une question d'équité. La Colombie-Britannique a toujours joué un rôle de leadership en matière de VIH. Rejoignons le reste du pays en ce qui a trait à la disponibilité du Cabenuva. British Columbia is being asked to join the rest of Canada in this new era of injectable antiviral therapy. Let's do the right thing for the men and women living with HIV in British Columbia. The next time someone asks me if they can be on Cabenuva and they meet the scientific criteria for its use, please give me the privilege of saying it will be a pleasure to write the prescription for you. Thank you. Merci beaucoup.